Okay, good. So we'll call the meeting to order. Roll call.
Yes, do you want me just to go around the room?
Our members are quality committee members. So that would be Lindy Jones here, Kenny Rose here.
Shelley Beering
Sure.
here.
Anyone else on that?
I think Lisa is, well, I don't know if she's here.
Huh? That's it?
I
Okay.
can ask you the other iPhone is, I don't know if that's a play.
Other iPhone? First iPhone?
I think the iPhone is Robert Pollock, right? No?
Yeah, it has a name.
No, that's not me.
Oh, it's not you? Okay, all right, sorry. Let's just go around the room then.
Sure, Sharon Price, present.
Ron Award Quality.
Ian Warden. Lindy Jones.
Shelley. Charlie Truman.
Maybe Solomon Gross. Helen Geiger.
Tim Collins.
Kim Stout. Amanda Williams.
Okay, no.
Gail Moorhead. Evan Couch.
Chad Brown.
Ray.
Joe Warner.
So the agenda's out there. I proposed one change to the agenda. I would like to remove the Press Ganey stuff for this meeting and hopefully arrange for a meeting to discuss this once we have a better once I have a better handle on the and other people of the committee have a better handle on the data.
There are two press Janie.
Yeah, both of them. Yeah, both of those, yes.
Do we have any more paper agendas?
I can print some. You want to look at mine?
Yeah.
I can look over. Lindy.
Well, I'll give it to them.
Any other changes or questions or about the agenda? If not, go to the removal and move to
So can I just ask one question? So will the goal be then to discuss this at our next meeting?
the goal that I hope after this is that we will arrange for a meeting later in late April or early May to discuss an extra quality meeting once that we have a chance to look at the data that went into the two reports there to make certain that the reports and the data answer the questions that were outlined by the quality committee when we asked for the staff.
Okay, so question I have is, and this may be my lack of knowledge of how Press Ganey works, is do you get to pick questions for the Press Ganey or questions? They're just the same questions across.
Mr. Chair, can I answer that? I think that this is a standard survey that's done around the country, okay? The thing that when we looked at this today, I didn't get it. I actually got it last night. I didn't actually be able to read it this morning. And then after talking with Dr. Jones, and we thought that this was not enough data to bring to this committee, even though that we had it already in the packet. We thought that we needed to have kind of a little meeting with the quality chair and CEO and Gail to just discuss it and really make sure that we are able to have proper information going forward to the chair or to the committee, so we'll be able to answer your questions. So I think that's why we're moving it off the agenda. So it's if you have specific questions, I think concerning this, because it's not going to be an agenda item today, I think that maybe you should maybe we could reach out with maybe or myself or Ian and kind of ask them and look forward there, so we don't talk about something that's not on the agenda any longer.
Okay. Thank you.
If that works.
So can I get a motion to approve the amended agenda?
Make a motion to. Oh.
Any public participation? Hearing none. Could I get a move to approve the minutes from the January 12th meeting?
I make a motion to approve the minutes from the January 12th meeting.
Second,
Anyone else? Okay. So a movement, so I guess, yes, we've approved the minutes. Okay, sorry about that. Okay, old business. Gail, voices of the patient.
Yes, my voice of the patient is from a patient who had come in, and sorry, I just forgot to have this running on my phone here, but let's find it. Okay. So, dear Mr. Warden and senior leadership, recently and unexpectedly, I found myself a patient at Bartlett Regional Hospital in January. I fell at home and my husband brought me to the emergency room for evaluation and care. I was promptly triaged and evaluated by Kendall and Dr. Ash. They provided skilled, compassionate care, working with Mike in radiology and Dr. Hernandez to evaluate the nature of my injuries. Dr. Ash worked with virtual radiology services to determine I had fractured my right humerus in my right hip. My pain was well controlled and I was treated with respect. I had an orthopedic consult and was determined by admission to Med-Surg unit in January. The Med-Surg team, primarily Chris on day shift and Callie RN night shift, primarily cared for me for the next 2 days. They were attentive to my pain needs, positioning, and communicated well between the shifts. The CNA staff who worked with them and the charge nurse agreed also are to a smooth, seamless care from ED to discharge. My surgery team, led by Dr. Wobler, was incredible. Not only did they come in on Saturday, but they personally introduced themselves at the bedside. Anesthesia discussed options, and we decided to gather general instead of spinal. Dr. Wobler was very thorough in his explanations of surgery options and how my complicated medical history impacted my care. He consulted with my specialist in Swedish in Seattle, as well as an orthopedic oncology colleague. Dr. Kerr also introduced herself as well as the nursing team. Our Med-Surg to PACU and back was seamless. My family had communication the entire time with Dr. Wobler, visited my husband and daughters immediately post-op. The physical rehabilitation team of Megan and Aaron saw me over the weekend. They not only assisted with PT, but helped me. Dr. Welling and the case management decided whether home health or outpatient PT was best based on my inpatient progress. I was discharged on Sunday, much to Dr. Wobler's amazement that I was up walking within an hour of surgery and laughs on Med-Surg the next day. The team saw that I was meeting my goal to return home safely with family support. So this patient had lived in Juneau since 1978 and has been an outpatient, but not an inpatient before. I am grateful and impressed with the stellar care, and please thank everyone. And this is the type of care that our staff are doing at our hospital. And I just wanted to share this with you as a voice of the patient. And it is National Patient Safety Week.
Thank you.
Great. Yeah, Eric Wobler's been a great asset to our medical team. Okay, so is Dr. Ash, so is Dr. Kerr, so. All right, Bartlett Regional Hospital Quality Dashboard.
Yeah, and if we can zoom in just a little bit, I know we're not gonna fit the whole dashboard on there. But I just want to present, new dashboard. The quality team's been working on this, for a little while now. And, it's a more comprehensive dashboard than what you've seen previously in the meeting. Before, we were really only able to focus on 2 or 3 metrics. But we wanted to really give you a feel for everything else that we've been working on in the hospital and just other, how we're kind of grading in other areas. So, we'll be posting this, prior to the meeting, so we'll have to really review it, just bring any questions that you have towards the meeting. And I will just point out, we've kind of divided our metrics up into pillars, and you can see kind of the more specific measure next to that, what we're looking at. We are going to change a little bit of the wording. Right now we have owner up there, but you may see a little wording change here and there as it develops. It's going to be a very dynamic sheet, right? It's going to change. We've got some targets and actual numbers, and then kind of where we are status wise, just so we can kind of see at a glance where we're at with what we're looking at. Right? And you can see just an explanation of the pillars. They're just different areas kind of where we put measures under, like care, exceptional clinical care, things like that. So pretty self-explanatory. We do have some determined studies that have just been adding the measures in, and are still coming up with our numbers and kind of contacting staff who are kind of in those areas. So.
So the different color schemes, just explain
Oh, okay, yeah, so.
each one of them so that they can.
Complex system, pretty basic, so we have, the green, which means everything is graded on track. And maybe I'll try and change up the colors just so you can see the writing a little bit clearer there, but so yeah, green is on track, we're kind of where we want to be, we're either, at benchmark or above like the average that we would like to see it at. The yellow is kind of at risk, where we're maybe not where we want to be, but things aren't so, we're still okay, but it's just maybe not quite where we want to be reaching. And then the red, we're just kind of not quite at all where we want to be, maybe a little bit below standards, and have some work to do in those areas.
Then you've also grouped the rows into different colors, the 4 or 5 colors are.
I think that was for ease of reading. Yeah.
That's
So
the pillars, right?
the pillars, yeah. So that's just for ease of reading, because it's a lot of information on there. It's easy to read once you kind of look at it individually per line, but we just broke the pillars up by color. Yeah.
Can you please explain to the board, of course, my mind was started, but the HCAP stuff, so we understand.
Oh, yeah, right, okay, and I might have to pull in my coworker Robert, and are we talking, can we go down?
So achieve 85% HCAHPS percentile.
HCAPS inpatient survey rating, like he recommends, just explain HCAPS and stuff, so that.
Right, so the HCAHPS, that's our hospital inpatient survey, so they get sent out to our inpatients, and we are required to receive CMS. And Robert, I'm gonna have you jump on and just kind of explain the 85%, because it was so much better than me, so I'm gonna just.
Yeah, so we're looking for top box, which is 0 to 10, the percentage of people that chose either 9 or 10. And that's where our actual is and our goal. So it's top box 9 or 10, that's the percentage of rate the hospital 0 to 10 is what you're looking at on that one.
And are there specific questions or just rate the hospital 0 to 10?
That is a specific survey question, and it's just isolated.
You can see like likelihood to recommend.
Okay.
Again, it's small writing, I can't quite read it. And staff work together to care for you, so they are specific questions.
Yeah, so just like when I looked at this for the first time, if you had somebody from the city or somebody maybe from the paper trying to digest this, it would be very difficult to pick up on these acronyms. There's 9 different colors here. But as I noticed, there's a lot of space at the bottom. I suggest you use footnotes to tell a reader who doesn't know this stuff,
Yeah.
what these colors are, what these acronyms mean, and any other jargon. There doesn't seem to be a lot of jargon in there. But
Yeah, we can absolutely do that.
Thank you.
Yeah, 100%, very easy. Yeah.
any other?
Yeah, sure.
I want to first say that, I was looking at pressure ulcers. And the fact that it was zero, first and second quarter of 23, I wonder, I don't know why it gets down. But if you keep it at zero, believe me, you're doing a good job because the first, you know, when I was in California doing for witness to long-term care for the course, this is what I zeroed in on, you know, as you probably know, because it means so much to how the overall care is. And even earlier, right now, the national rate is 9.1%. What you've got in there is that your goal is national and state. That shouldn't be the goal. 9.1 is your goal should be, because that shows the overall. I mean, it really does show overall care. I didn't see anything in there on hydration, but maybe this good spot for it. But you know, that's the second thing you look for when you're trying to sue somebody. Is, you know, what was the hydration? And you don't see that, but I'm real happy about the pressure on all foods, especially if you keep that up. The other thing that concerns me is your restraints and seclusions. Well, there isn't much in there, and I mean, what's the procedure on restraining a patient? What's the procedure on secluding a patient? And you got it in progress. Well, what?
I am so sorry, guys. I apologize for that. I probably should have put something in there other than in progress. I just need to collect that data. I have all of the data for our behavioral health units, like we have that regularly tracked, but I just didn't have it at my fingertips to put in there, you know, our other restraints, like medical restraints that we track other than behavioral health. So it's just a matter of putting that in. Again, like this is so dynamic and it's so new, you know, and it was so much to put in there, but it's just a matter of us getting those numbers in. So hopefully we'll have more filled out for the next board policy.
And then through the chair, we actually just transitioned from, we used a system called T-Systems in the emergency room, and we just transitioned to Meditech in December. So now we're able to abstract better our restraint usage in our emergency room. So it was very challenging to actually track restraint usage accurately in our emergency room. So we couldn't pull the data effectively. So in the future now, for this first quarter, we're actually going to have a better accurate rate of our restraint usage in our emergency room.
Is there a procedure, and are we in compliance with the state and federal laws on restraint?
Yes, and our restraints in our MHU are well below national average. And our use of our seclusion room are also much below.
If that's the case, then
yes,
you need to, you know.
It will be updated for the next committee.
Because those are all major good points.
Yes.
I have one question for you. How do you measure hydration?
Well, there are a number of ways. One way is that if the patient develops kidney shutdown, they haven't been getting enough fluid, right? I mean, but that's the end,
Right.
kind of the end case of it. But I saw lots of and where they, you know, did catch each other. But hydration, you can have it. You can chart fluids. I don't know if you in the long-term care, you know, they touch the food and fluids and so on.
You'll be hearing that on when we get to our SNF. Yeah.
But you know, that's how you keep track of it. Keep an eye on it, and also the assessments could be blood pressure, could be skin temperature, as you all know. So there's a number of ways to.
Right, I'm just thinking of a system wise, how do you know, I know in an individual patient, this is how I know they're not hydrated or they are. But how do you as a system get a quality measure that says, 90% of our people are well hydrated, whether that be in a nursing home or the hospital or 100%? I don't know if there's.
Yeah, I don't know either. That's why I said I'm not sure if it belongs up here, but it's another major issue. And needs to be addressed in some way. My guess is as the nurses assess the patient and notice, signs of dehydration, then they would start a charting of how much fluid the person is taking and maybe even the Tylenol and so on. So it may not fit on this, but it is an issue.
Chair?
Yep.
I think it's great to see the new metrics and it's always wonderful to look up and see how we're doing. My question is for the red. I'm assuming you have a plan for that. And it would be great to see that when we get the packet, just. So
No, I totally agree with you on that.
I know it's a new system.
Yeah,
but
totally new, right? We're just putting the numbers on the board. What are we doing? But that's a great suggestion. We're gonna take that one. It's fantastic.
Yeah.
Just like the colors and, getting rid of the acronyms. Sometimes you just miss that when you're in it every day. So this is amazing feedback. Yeah,
Yes.
this is great.
And through the chair, the red is actually based, Deb and Robert have been working on a goal to move Bartlett from a CMS 4-star hospital to a 5-star hospital. So when they have red here, their goal is for the HCAHPS is they have all of it looking at is what will it take to move Bartlett from a 4-star to a 5-star hospital? So that's where they made these metrics is this is what we have to achieve on all these different metrics that go into getting us to that next level. So that's where they have it. So maybe the next meeting, they can bring our A3, which is how we are working on our, thanks to Ian, how we're working on our process improvement. And they can show all the different factors that are going into this. And this is how we're tracking it.
one step closer.
Yes.
Kim, Wildflower dashboard, dashboard. Bobby.
But. So, these numbers really look great on my computer and then when you pull them up here, they're hard to see. So I apologize for that. So at Wildflower Court, we based, the metrics that we are working on. What we chose was based upon those that we feel have the greatest impact on our facility and those that we know we need to be working on. There are a lot of other metrics that we are actually working on that are not even on this, and I'll get into that in just a little bit. So in long-term care, one of your biggest areas of concern is always related to your falls. Falls are huge in long-term care. And I'm having to look at data from the calendar year. The Wildflower Court rate of 2022 is a calendar year rate because Wildflower Court was previously on a calendar year, not on a fiscal year like Bartlett. So I had to set a 2022, which was a full year of data, as what I'm comparing against. So you'll see the state rate is at 37.7% falls in Alaska. The national rate's at 43.7%. So for Q1, which is July, August, September fiscal year is what I'm working off of now. We demonstrated great improvement from where we were in 2022, which was a 51.8% fall rate. We reduced that rate. For October, November, and December, we really didn't move much. It's pretty stagnant right there at 43.6%. So, you know, my colors are kind of, I will make sure that I marry my colors up with Bartlett. This is a scorecard that I've used historically. And so my yellow means that we're improving but we're not where we want to go with a goal. And I kind of shaded a little orange because we didn't do any better. We're not red, we're not below, but we're not going the direction we want to. So the second metric we have identified at Wildflower Court is to improve our CMS 5-star rating. And I'm telling you, this one is always old data. So Wildflower Court star rating was in 2022 was a 2-star rating. And in Q1, I got data back and we dropped to a 1-star rating. Now, let me tell you, that hurts my heart. So we'll talk about that a little bit. 1's the worst you can get in a star rating. And so you dig into what in the world's going on. There are 3 areas in long-term care you're measured on. That there's multiple items in those 3 areas, but 1's on your staffing, and we were a 5-star rating. 1 is on your quality of care. We were a 5-star facility. The other one is on your surveys, which is 3 years of data. It don't drop off for a while, just put it like that. And we were a 1-star facility when we were at that 2-star. So we dropped to a 1-star, and whenever I dug into the data, it was based upon the fact we dropped to a 4-star in our staffing at Wildflower Court. So what does that mean? Because our staffing levels really didn't decrease, but I got to digging into it, and it showed that the nursing home administrator was present 25% of the time for the months of April, May, and June. So as I said, we're behind the quarter. That was inaccurate data because I started in April and I was there all the time. So, but I was employed by Bartlett, not by Wildflower Court at that time. So you see how that happens that way. I went over to Wildflower Court in April, but I was a Bartlett employee, so my data didn't pull out of their payroll system. Anyway, so that's what happened right there. We dropped from a 5 to a 4, which dropped us on down to that 1. So, you know, the positive here is we can't do anything but go up. So we're working hard and furiously over there to make great improvements. The next one is related to our pressure ulcer rate at Wildflower Court. As I told you, we are a 5-star facility as it relates to our quality over there. And our Wildflower Court rate in the year of 2022 was 2.9%, which was still way below the state and the national pressure ulcer rate. And we have had no nursing home facility acquired pressure ulcers from July through December, which is what period I'm reporting on. Urinary tract infections, in 2022, our rate was at 1.8%. The national rate's 2.5 and Alaska's 4.2. We had 0 UTIs in Q1. We had 1 in Q2, which increased us to a 2.1%. So that is something that we immediately re-educated staff on, and we are watching that. My goal is to not have any indwelling Foley catheters, but sometimes that can be helped. So the other one is just one of those little performance improvement projects we're working on to make sure that we have hospital grade outlets in all of our rooms. And you know, we're just keeping track of that. And we've increased from 84 to 90%. We will have that met by the end of June. The next one is Wildflower Court licensed nursing staff will be deemed competent in the care, maintenance, and administration of intravenous infusions by June 30th. That's so that we can help Bartlett by getting some of those long-term patients out of Bartlett into subacute rehab that qualify, and we can provide that 10 to 14 day to 30 day treatment course of IV antibiotics. We're putting them through that because our nurses have not provided that service in quite some time, and many of them have really never even dealt with things such as PICC lines and some of those things. So we actually employed a nurse that is very talented in this, and we're working with Bartlett's education department. So I think a plan is already being initiated, but the goal is to be done by June 30th. The other ones are the other three metrics that we're looking at all impact our quality outcomes as well, and which impact that star rating. And one of them is improvement in function on our subacute rehab residents that live there. And the goal is to improve on that. You'll see I have arrows on there. And we're below the, for the year 2022, we were below the state and the national rate. However, for Q1 and Q2, so July through December this year, we actually hit it well at 80%. So we're above the state and the national on improving the function in our subacute rehab residents. The other one is a metric that you want to see trend downward, and that's that our long-term care residents moving independently worsens. We don't want them to worsen, okay? So we were above, we were not doing well in the year of 2022, and we were above the state and the national rate, and we are trending down, and we are lower than year 2022. So you can see I moved the 22.2 to a yellow because that was demonstrating improvement. We weren't where I wanted to be, which was at least at the state rate. Goal, of course, should be national rate, but I want to see continual improvement. But we kind of slipped back and went at 25% for Q2. Still better than 2022, but not the direction we want to be going. I have met with our rehab staff on this issue. And then, of course, to increase our census, that's a goal, and to 90% occupancy, but that's based on staffing, and that's just something that I'm kind of measuring for my own benefit, because I would like to see us to be able to grow our volume over there. And we are not at the goal, which was 55, which was what we set. May need to revisit that at some point. So that's basically the Wildflower Court scorecard. Any questions?
I do. Is there a state or federal mandate for the number of hours that a resident receives care? In California, there is.
There is. We are measured. They're looking at mandating new rates at this point in time in Alaska, but it has, well, actually nationally, they're trying to make it through a national mandate, but that has not went through the approval process yet. But it does impact us negatively if we are not meeting the rate that we're measured against, and we do well over there.
Through the chair. For the IV stuff, why would you color that red when it isn't due to be done until June?
Because we haven't moved yet on it. I set that goal in whenever I wrote the scorecard. I wrote it in June of last year. I gave me a year to do it, but I'm not even, we haven't even started the training yet. And so I'm getting a little anxious. And you're right, I probably didn't have to turn it red because I'm not at the deadline, but I feel like it's red in me because I am hitting here at March. We're getting ready to start our last quarter of this year. But you're correct. I probably should not have because I'm not
It's in
in the
progress.
Yeah, it's in progress and I'm not there yet. You're right.
Hi, this is Lisa. I'm sorry, I was a little bit late. This was a great presentation. I do have a question though about your therapy department and rehab. Are they fully staffed? And have you looked at the process of how it's communicated to them that residents might need therapies?
Yes, and we are fully staffed. We did lose one of our restorative aides. She retired after many years of being at Wildflower Court the end of December. And we have recently replaced, and we have 2 restorative care aides. And for anybody that knows long-term care, those restorative care aides are very instrumental in that moving independently worsens category. So, but we are adequately staffed. I'm working really hard to educate. They know their role, they know what they're doing, but they don't, from what I gather just by visiting with them, I don't think they had ever seen the scores, the outcomes after they come out. So we pull that from our MDS data and we can really get to it at basically any time. And I don't think that they realize that we might need to really drill in and focus on these categories.
Thank you.
You're welcome.
Any more on that? Now you have home health and hospice.
I do.
Okay. Now we're gonna move on to, my battery's died. The home health dashboard.
So I'm going to introduce you to Amanda Williams. She is the clinical manager at the home health office, and she is going to present her home health scorecard today.
So all of these items, save one, are things that are tracked by CMS. And it primarily comes from one type of assessment that we are required to do. And then a couple of items on here are claims-based data. So we don't have data on that right now. So I'll just start at the top. So the first, well, and these, Kim chose these items, but you know, they're kind of big picture items that I feel like shows the overall health of your home health agency, so to speak. So I feel like these were good items to start out with. But when we look at the first one, how often patients experience falls, we're doing really, really good here. I pulled this from a report that it just shows all of the falls that our patients have. It doesn't show which ones have major injuries, but this is inclusive of all of the falls that we have. So I think we are doing really good here. And we'll just keep doing the work that we are in fall prevention. The second item, how often patients get better at mobilizing themselves. So we are struggling here. That's 65% is what we're at right now. And our goal is 84.6%. So where this data pulls from is it's based on that specific assessment. And I think we can improve this number based on education to the clinicians on how to answer the questions within this specific assessment. We actually have a training coming up in a couple of weeks with our the OASIS assessment with our OASIS scrubbing team to go over some items with us. And then I've looked at a couple of online education platforms to get our staff education for this type of assessment as well. So I think this number will improve And I think we will be able to meet our goal. The next item talks about admitting patients to home health in a timely manner. And this is by far our biggest struggle. We're at 44% here with a goal of 91%. And so per CMS regulation, to admit a patient to home health services within 48 hours of receiving the referral, or within 48 hours of that patient discharging from a facility, whether it's a SNF or the hospital. So, and this was also an item that was, we had our state survey last week, and this was also an item that she talked about. So our challenges here, a few challenges here. We weren't routinely admitting patients over the weekend. So if we were to get a referral on Friday, then, then we were sort of dead in the water, because we were gonna surpass that 48-hour time point. And so we've talked to our primary on-call nurse. And so she's, in fact, last weekend, she did an admission. So we're gonna try to pick up in that area. Another problem that we've had is we have a full-time travel physical therapist right now, but we rely on the hospital to provide our occupational therapy and speech therapy. And so there are a lot of times where if a patient only has therapy on their referral, we have to wait for availability for that therapist to admit the patient. And so what we're trying to do on patients when it's appropriate is review the clinicals that are sent with that referral and see if there's anything that a nurse can address specifically, and then asking the physician to add nursing onto the referral, because our nurses have sooner availability. And so that has worked. We've done that with a couple of patients, and that I think we'll pick up some percentage points there. But I feel like the biggest challenge is when I call these patients to schedule their admission visit, sometimes they don't want to be seen until the next week. And I can reason with them about, if somebody's just come out of the hospital, we want to make sure they don't go back, right? And so, I'll reason with them about that. I'll reason with them, your physician's concerned, the sooner we get in there, the sooner you can get better. And sometimes they just refuse. And we can't force ourselves into someone's home. And so I feel like that will be our biggest challenge on that front. And I'm still thinking of ways to try to convince patients to let us get in there sooner.
Chair, wouldn't that be an exclusion from your data though, if a patient doesn't?
So I brought this up with our surveyor, and she had the documentation there, called, the patient didn't want to be seen, called and left a voicemail. Sometimes we go to the admission visit and the patient decides that they don't want to be seen, right? So she didn't give any indication that would be an exclusion.
It seems like we will see how she writes that up. Because you have no control.
Correct. Yeah. Well, but then, I feel like, well, we don't have any control over it, but then I look at the state rate and the national rate, and I'm thinking, how are they getting in there? I've thought about calling other clinical managers within the state, right? Because I feel like culturally, their population is gonna be most similar to ours and say, you know, have you dealt with this before? And how are you able to get into those homes quicker? But yeah, that's definitely the biggest hurdle that we'll have to overcome. The next one here is how often patients are being admitted into the hospital. And so this would be admitted with an inpatient status. And from our patient population that we have so far, we're at 3.6%, and that's well under our goal. The next item is how often our patients are seen in the emergency room. We're at 2.8% there, and that's well under the goal as well. The next item, we don't have any data on. This is a claims-based item, but it will be measuring, it will measure how often patients are coming into the hospital for preventable conditions. The next item is growth in our census, and the goal was 20, and we achieved that in the first half of Q3 here. And you know, I expect if we're able to continue admitting patients, I expect that to grow. Just based on my time working at the previous agency, I feel like our community can sustain double what that number is easily. And the final item on here is how much Medicare spends for an episode of care. We don't have that information yet. That's another claims-based item. So that's my scorecard. Is there any questions?
Let's go through the hospice then.
I'll go through it quickly. Heather is out at a training today, so Heather is the clinical manager at hospice. So again, their scorecard you can see is green all the way through. Fall rate will be at or below the national rate, and on our hospice side, we've had 0 falls. A lot of these are also claims-based data, and as you were aware, we have not obtained all of our licensure payment numbers and everything to begin billing. So we're waiting on that. Once we do, we'll start getting these results back. But hospice visits in the last 5 days of life, these are things that are measured and were compared across the US on. The patient will receive at least 2 days with visits from an RN or a social worker during the last 3 days of life. So we're at 72.4% on that, and which is higher than the national and the state. Patients who got an assessment of all 7 HIS quality measures, that is their comprehensive assessment. 97.7%, which is higher. Pain will be effectively managed and controlled. We're at 100%. Constipation will be effectively managed and controlled. We're at 100%. And hospice will have continual growth in admission volume. And we look at this on an average daily census, and we're running, I'm telling you, it's hard. We'll admit them, and then 2 will pass, and we'll admit them. But that last quarter, we were at 5. So this is a challenge that we are going to continue to brainstorm and work on to see if we can get more referrals in a more timely manner, because it seems like we're getting the bulk of our referrals within the last week or 2 of life versus 6 months of life. And then of course hospice will become a 3-star agency, and that's just a measure that at least a 3-star. Our goal will be 5, of course, but and that's something that we'll measure whenever data starts coming out. That's my report.
Yeah, I think one thing that is important for us to look at is that length of stay in hospice and that we really need to figure out a plan, an action plan to increase that length of stay, because there's no way that we're gonna be solvent if we have people that are there for 2 days.
You're correct.
So, that's very important, that we, that we train us doctors and train the community that you don't go to hospice 2 days before you die.
We need a few Jimmy Carters.
You might
Need a few Jimmy Carters.
Yeah, we do. Exactly, that's right. Perfect, yeah.
So is there a plan for outreach to the physicians?
Heather and Dr. Peterson have already begun doing training with the physicians. They have been to a medical staff meeting. And we're gonna work with Heather and Dr. Peterson will work to try to get on more agendas and to be able to do more education with the doctors, but it's also it's a cultural Juno. And so I think that education to the community as well is a priority to us.
And the native corporations?
I'm sorry.
And the native corporations?
Absolutely. Absolutely.
Patient stories.
Oh, I agree. And we have done some of that, but it's been a while since we did it in, was it September? We had stories and they were played on the radio and things like that. But we will re-engage and work harder on that. We've been working so hard on getting it open.
Yeah, and your survey still.
Thank you.
I think, the community is very supportive, but of hospice, as how and end of life care. But, we do have a responsibility if we're gonna make it work to make sure that we use it to its fullest potential, and actually patients get a lot better care.
Right.
Just, if that's Jimmy Carter going on to hospice, not death sentence. So,
No, I just kind of was agreeing with what you guys are saying, and not just the education for the physicians, but also education for the community too as well. To know that Jimmy Carter's need a lot of.
all right, anything more on that? Thank you. And, okay, so now we're gonna go to Cam again, Wildflower Court Survey.
So Wildflower Court had their health survey finally. We've all been waiting on that for 5 days, and I did get our report back. And we had the positive is we had 0 civil monetary findings. Hey, that's a good deal. I'm serious. It really is. And we had no conditional level findings, but we had 20 findings. 8 of those were duplicates because it was a state and a federal survey at the same time. There were 8 on the federal survey. There were 12 findings on the state survey. So there were duplicates. Okay. I may have said that wrong. Anyway, there were 20 findings when you add them up. They're all minor, and I actually pushed the button and sent the corrective action plan yesterday evening on that. So now the work really starts on that. And so I'm waiting to see now if they accept all of the corrective action plans that were submitted. We have a team and we've been meeting regularly, and we will continue to meet to make sure we're on track with those corrective action plans. We also had, the next week we had our emergency preparedness and our life safety survey at Wildflower Court as well. And we had 5 minor findings, and we had that report turned around within 48 hours from the surveyor, and we turned around our corrective action plan within a week, and they accepted it. So that one basically, and everything is due, all of our corrective actions have to be implemented and in place by April 1st on the health survey, and by April 8th on the emergency management and life safety survey. Just one more.
Yeah, could you give us just a few representative examples of those 20 findings you said mostly were minor? Just what kind of things were they?
So, let's see, this one right here. So one of them is related to they noticed that a resident had their glasses taped. And so they went into the care plan immediately to see if we had an ophthalmology appointment scheduled, and there was not one. So that resulted in a finding. Another one was they observed some failure to follow proper hand hygiene. Seems like that's one that you fight continuously. And we had a finding for you have to issue your advanced beneficiary notices to your subacute rehab patients at least 48 hours before they're discharging to allow them the opportunity to appeal the discharge. And there were a couple of them that had signed their advanced beneficiary notices having received it, but then they chose to discharge earlier than the 48 hours, and it doesn't matter, we should have issued it earlier. So that was a finding. One of them, some pharmacy issues. So Juneau has one pharmacy that Wildflower Court has utilized basically the same pharmacy forever from what I gather, and they've had a change in ownership. And so in long-term care, we're required to have a consulting pharmacist that comes in at least every month and does a 100% drug regimen review of every single resident there, at least every month. And during the change in ownership, unbeknownst to us or them, the pharmacist quit because this pharmacy now uses a telepharmacist. And we're seeing a lot of that. Pharmacy is a challenge in Juneau. And because in long-term care, you use blister packs versus bottles of pills. And most pharmacies don't do blister packing here in Juneau. And so we got cited for failure to get the drug regimen review done. However, kudos to our director of pharmacy at Bartlett. He came on site while they were there and caught them all up for us. And we have already corrected that because we have a pharmacist at Bartlett that has long-term care experience that will be picking that up. The challenge, however, is they also, another finding was related to them looking at some of the blister packs, and the pharmacy had filled the wrong dosage in the blister packs. Nursing had caught that, and nursing had notified, and we had the documentation. But as they kept looking at all of the times, they wanted to know how many times did we contact the pharmacy. They've got them all documented, and you're like 5 times we notified the pharmacy. So the accuracy of the drugs was also a citation. So
those were from the outside
it
pharmacy.
was from the outside pharmacy, not our pharmacy. It was an outside pharmacy. So we are looking into what other options are available in Juneau for us to look at from a pharmacy perspective. Those are some of the examples.
So, so you caught the pharmacy problem, and they still cited you? Why did they cite you?
You know what? When they did our exit interview, they brought it up and said, we don't know what we're going to do with this. So this is an extended survey. And they went back, and then this is how it came out because they didn't know what to do. The pharmacy wasn't under survey. So how did they didn't know what to do.
You're the gold star.
Okay. Thank you, Mr. Chair. So we can't just use Bartlett Pharmacy?
It's not a retail pharmacy.
We changed that.
Yeah, I mean, we need an outpatient pharmacy. Yeah.
So terrible.
One more thing on the list.
When did I say?
Okay, well, they will. Okay, yeah, all right, that was my question. That's a foundation first. All right, home health care hospice.
So
survey, yeah.
we're still waiting. Hospice survey has been completed since December and we're just waiting on numbers. So there's really not anything to cover on hospice survey. Home health had their survey, week before last week. They're all running together. We've had one survey every week now for a while, 5 days, all week, last week. And, we're looking at, and this is our actual full survey for licensure because we've been working on a provisional. And we're anticipating 4 to 5 possible findings that we're gonna have to correct. One of them's delay in treatment. We know that. I'm trying to remember. One of them was
Document our grievance,
complaint resolution. And the complaint was resolved, but the documentation of it, easy fixes, I will say that on them. So we're waiting on the report because I don't know how she's gonna write some of them up. So until I see that, I'm not gonna be sure. But they have 10 business days to return the report, and we have 10 days to provide the corrective action report.
Getting there. Are they showing us the money yet?
Not until we can bill, no, we have to be fully accredited, have a provider number and all of that. And so, on hospice, it is almost 90 days since all of this. And so the state has 45 days to push their information to CMS, and CMS has 45 days to complete their process. And that was December 26th. So we should be hearing any day and get that cleared out so we can begin billing for hospice.
Any more before we go on to Rhonda and?
Okay, I'm gonna do Joint Commission readiness status. Basically where we were and where we are now. The last survey was in December of 21, and it happens every 3 years. We are actually in our survey window now. I'm anticipating hopefully that they come like in the fall, like in October. And where we were was last survey 3 years ago, we had 35 elements that were non-compliant. Most of them were low and moderate. Some were corrected immediately. Some needed some big construction projects, such as the mental health unit. New doors were placed that were ligature resistant. And that is all completed now also, except for maybe 2 sets of doors that might need to get replaced in the future. Some of the survey results from 3 years ago needed new processes put into place. And we did corrective action plans and submitted proof of completion of some of those new processes. And for the hospital, it got signed off for compliance back in April of 2022. The behavioral health aspect of it has a date of 6/2023, but that was related to the program that got surveyed after the 2021 survey, and that was related to the applied behavioral analysis unit. So that was last successfully signed off in June of just last year. So now we're focusing on like getting ready for our next survey. So the priorities for 2024, I focused on the survey results that were from the 2021 survey, because I think they will look at what our last survey results were, and they'll make sure that we are still compliant on what we had left over from there. And that is where we're focusing on to begin with. And it has to do mostly our biggest survey related issues that were the highest non-compliant was related to suicide risk screenings. And that's how we opted to implement the Columbia suicide risk screening for universal for all our patients over the age of 12. We are doing proactive risk assessments for ligature risk, screening the successful completion of the Columbia suicide screening, and we're doing pretty good on the ligature risk assessments, and we are doing pretty good on those Columbia suicide screenings. We are still in the works as far as making staff really comfortable asking those specific suicide related screening questions, but we're getting there. The other issues that we're working on is emergency management. We did a proactive all hazards risk assessment, and that was one of the areas that they wanted us to work on. We have another area that I am focusing on is like whenever we have new processes, such as the new robotics operation surgery that we are doing. So I look closely at that program as far as like, are we following all the procedures correctly? Are we showing evidence that we have like good competency in the robotic programs? And from my investigations, things are going well with there. We haven't had any major incidences. The staff is feeling comfortable with the robotics. Our disinfection procedures and central sterilization of the robotics is going well. So I feel comfortable with that aspect of it. And another thing for the Joint Commission is that they're really emphasizing workplace violence prevention programs. So we have an active workplace violence training in for our staff and for our actually physicians get a little workplace violence education component to it also. I am looking at tissue tracking for surgical services. That would be like for tendons and bone grafts. And we're monitoring those procedures. Of course, like the high risk procedures we're looking at closely is high level disinfection and procedural sedation. I think we're doing well on those processes. And then let's see, the next slide is pretty much just basically the same thing. I added on this slide that we actually have 2 new GYN oncologists that are doing the robotic surgery also. So that is just going to grow that program. And I think I added MRI and diagnostic imaging because we are having the new MRI machine actually in place, and that should be up and running shortly. I think that project is going well, and there hasn't been anything associated with the new MRI construction project being built, but we have to monitor for risk associated with a construction project like that. And then before the MRI actually comes online, there'll be some added drills and processes to go through to make sure everything is safe from the Joint Commission viewpoint. We're going to still consider continue to assess the water management plan. We're updating that. The continuing all the maintenance and drills that are required. We're doing well on that. This just shows some of the different elements of performances and standards that we have to look at for Joint Commission. And since I divided it, since we had 35 episodes of areas of non-compliance, for the first quarter, I really focused on all the high level things. The second quarter that I'm actually already starting into, I'm looking at all the moderate, different standards. And then the third quarter will be all the lower standards, even though some of those have already been looked at in the meantime also. So the next slide will be just some of the more different areas that we're focusing on from the Joint Commission viewpoint. There is so many different standards and areas to focus on that it's very broad. It goes from the utilities of the hospital to the security plan, to med staff involvement, to education and training. So we are really looking at a lot of different areas. The next slide is continuous readiness. We try to be continuous ready. We do daily roundings, we do a lot of risk assessments, we do tracers. I have a few people who volunteered from different areas to help me be Joint Commission champions. I have Luke Dilla and CCU who's helping do tracers. I have Lydia Steele in ER who's helping do tracers. I have 2 nurses on mental health unit that is helping do tracers. So it's like a lot of eyes looking at things from a lot of different angles using a standardized tracer form. So hopefully we'll be able to be proactive and identify areas that might need a little bit more tuning before the surveyors come. And as far as board members, you guys are very important. The governing body kind of plays a role in setting the tone for quality and safety, and we appreciate your questions and your input. Research has shown that higher performing healthcare organizations are correlated with well-educated boards that discuss and monitor quality and safety in measurable, meaningful ways at every board meeting. The dashboards that Kim and Amber and Amanda and Deborah showed actually kind of like builds into that evidence that the board is adding to the quality, participating, and supportive of being Joint Commission accredited. So thank you. As you know, we have regulatory requirements, CMS and Joint Commission. Next. And how does it relate? Yes, the board is a governing organization and ultimately responsible for our healthcare organization's tone and success and our goals. Next. These are some enablers of the board effectiveness. For you guys to be effective, it funnels down into the rest of the hospital. So I think understanding the function of quality and safety and how it adds to care delivery in the hospital is pertinent. The board of the hospital holds our leadership accountable for positive changes and sustainability. So thank you once again for helping maintain that. Asking the right questions. Thank you for asking the questions, which really adds to the discussion and the quality of these meetings. And I think our board should align with the community served. And I think our board here does align with our community of Juneau. And I thank you for that also. So I put this slide in here because everything that we do, being accredited, doing all these quality meetings, we want patients to have like zero harm. That's our goal. You know, so we set the standards high. And how do we do that? I think the good processes, good people, good environment is the answer to that question. We don't wanna set a goal of 99%. Even though 99% sounds good, we wanna set a goal of zero harm. You know, we don't wanna have like a 1% patient harm rate. If we had a 1% patient harm rate, that would be like, one statistic said that would be 200 patients' deaths every, like day, nationwide. So that's why we set a goal of 0 to really try to keep all our patients safe. And then the next thing is, I am in the lead person on the Patient Family Advisory Council. So I want to share something about this council. We have a new Bartlett page for the PFAC Council that is up and running right now. I put these paper brochures on because we have a QR code that links to it and links to our online application. We want to be a patient-centered, family-centered healthcare organization. And in order to do that, we need patient and family advisors giving us input on the different materials that we give out to our patients. We want patient-friendly materials. We want to have a healthcare organization where the patients and their family members want their patients to come to us for their care. So if we have a council that is a partnership with families and patients, adding their input, and they feel like they have a valid say in what the hospital does for procedures, policies, care, that will actually increase patient satisfaction, increase our reputation in the community, and should be a win for all. So I am looking for past patients, past family members, and I want a diverse representative. So this slide actually shows, I want like a male community member to represent Juneau so that we have a lot of sportsmen, we have a lot of retirees. We want our PFAC council to be representative of what our community is like. We want an ethnic representation, and we have a large Filipino community, so I really would like to get a Filipino representative on there, Alaska Native. So I'm looking for members that might be a good fit for this organization, to be on this council, to add their voice to our hospital. And that's, when patients' family viewpoints are integrated, the practice is more prepared to respond to their needs, what matters, their priorities, and their values. So I think it's a win-win if we get a variety of patients and families on this council. So I'm looking for you to, if you have any suggestions for people who might want to join and be good communicators, good with voicing their opinions, that'd be great.
Thanks. Any questions? I just have one comment. I'd love to chat down with you and the JCO rules on universal screening for depression.
For depression or for
suicide risk, because
they haven't started with the depression one yet.
No, that's all it is.
We opted for universal and
yeah.
yes, yeah.
I just the data suggests that it is it doesn't do it. But we've chatted on it, so, and it is a lot of work, and it I think we really have, one, what is our requirements for JCO? And two, what is the most effective way that we can screen thoroughly the people that are at high risk. And so, looking at, universal screening versus targeted screening. So anyways, I think that's a bit of a discussion, but, I would love to chat with you about that because it's in the ER, the universal screening is, it just, there's 3 or 4 questions, but again, it's in a way, it really, it doesn't, the data shows that you can't pick out those people based on that. So if we have to do something, that's one thing. There's a way to do something that's more effective, that maybe, so we put the energy in the people that were more likely to find something and make a difference.
Yeah, we definitely don't want screening tools to get screening fatigue.
And this one doesn't.
So that's always a
Yeah.
concern. So we have to keep track of
Right.
things like that, and then we have to work on evidence. Yeah, evidence-based
Evidence-based
practice is always
Is
a good way to go.
Correct.
And
Absolutely.
from Joint Commission, one of the things is that you always want to follow your policies.
Right.
Because they sometimes don't tell you exactly what to do. They don't tell you to do these 5 steps and you'll be compliant. They tell you, kind of like come up with these, safety guidelines, but it's really up to your policies to define exactly what that is.
Right.
So.
That's true, and with the action committee, if you want to have a conversation with me offline, I've got some great ideas for some community people that might really fit into their. So take my phone number from.
That would be great. I already have, I spoke at a Lions Club meeting. And I already have, 2 advisors, signing up already, so. I think we're doing good. My goal is to have 3 advisors for every 10, staff members. So that we don't have, too outweighted.
I just like the diversity, so that can help you.
Yeah,
That's kind of what I was.
Thank you.
Okay, anyone else for Rhonda? Thanks, Rhonda. Any community comments or questions? Committee, I'm sorry. Sorry.
I was wondering if you could take.
Oops. Okay. Hearing none, we're gonna go to figuring out, when we're gonna have our next meeting.
So, through the chair, I do have a comment before we go. So we went over an hour and a half on this, which I think will get quicker next time because we'll have a better understanding of the metrics. Correct? But if we would have had the presentation, we would have been way over.
Yeah.
So how was the agenda set? Since I'm newer to this committee.
Through the chair, we are scheduled from 3 to 4:30.
Oh, okay. In my thing, it popped up. So we're right. Fine.
So
I take that back then.
yeah, I think, we'll work on that. It'd be cognizant of time. Any other comments?
Thank you for all the hard work in getting metrics going. I know it's a work in progress, but it's very exciting to see. So thank you guys.
And through the chair, I think in the future, it might be, as you're used to the dashboards, it might be less explaining the dashboards and just answering questions on them if there's changes, as you're used to looking at them.
Through the chair, I have one suggestion on the dashboard. I'll talk it offline just to make it easier. And then, Dr. Jones, if I could make a recommendation about our next meeting.
Yeah.
I think that we talked about with you, Gail, and Ian. We should do that first, and then we can come back and send out a survey.
Perfect.
Great.
Yes, I know I will be gone the month of May, and that's when we would usually have a meeting, but.
Before that. Is that right?
Yeah, correct. So we'll hopefully have something in. In the middle of the latter part of April. Okay.
So we will adjourn. One minute early.
It's on my phone, it's. An hour.
You get it, Howard.
Oh. I'm not the only one.